Wonderful. Welcome, everyone. As it says on the slide, welcome to the Storytelling Community Catch-Up. And really, this catch-up, we've started to get them in the diary because there was a real interest within HBCA about adding storytelling as a tool to sort of a change management or a program manager's toolkit. And the first thing people asked for when they said, right, let's get a community, the first thing people asked for was guest speakers to talk through how they have used storytelling in their work. And then we can start also discussing within the community, sharing tools and what each of us are up to. So you can see from that packed agenda, we're busy doing one, and Lesley is joining us for two. But before we get started, as part of our welcome, I thought it's always good to sort of just check in and see where people are. So if you want to pop in the chat what dog you are today, just pop your number in the chat. I'm
Oh, I love them all.
yeah, actually, funny enough, I tried this on a previous meeting. There were lots of fives. Excellent. So we're getting a good sort of coverage of the dogs. Lots of fours, which I'm really pleased with. In a previous meeting today, I had loads of ones and threes, which made me think, "Ooh, this might get a little bit punchy." But anyway, lovely to have so many fours and a couple of fives. So without further ado, what I would like to do is hand over to Lesley. Lesley will speak for as long as she needs to, and then what we will do would be we'll have sort of any questions and answers, then move on to the final session. But just a reminder of some of the community rules. I know it's we've put it in the community space on the Knowledge Hub, but the main rule after this is Storytelling Club, and you will tell people about Storytelling Club, which is rule number 1. Rule number 2 and 3 and 4 all roughly say the same thing. This is about sort of listening with openness and listening with respect, even if people say things you don't agree with. It's about having that open and trusting relationship that we are in a safe space to share. As we, of course, as this community develops, if there are other rules you think we need to call out, let's have that discussion in the community space on Knowledge Hub. So you can sort of think about it, vote for which ones you think are most important, and so on. So I'm gonna take down our dog check-in and hand over to you, Lesley. Welcome, and thanks so much for making the time. I know how insanely busy you are.
Thanks, Bryn. Hello, everybody. I'm Lesley Goodburn. I work at NHS England in the Experience of Care team. And the work that I do is with provider trust, so ambulance, acute mental health and community trust, using something called the Patient Experience Improvement Framework, because in the NHS, you may know, we love a framework. It helps people, though, diagnose from a patient experience point of view where people are from an organisational point of view, looking at leadership, culture, collecting data, triangulating data, and learning from data. And I also lead on something called the Heads of Patient Experience Network. Funnily enough, it's a network full of heads of patient experience, people who lead this work, predominantly in provider trust, but also across integrated care boards, academic health science networks, cancer alliances. Increasingly, we're having charities, hospices. Anyone can join the community as long as the predominant amount of your work is around experience of care. So that's me, and I love stories in all the forms. So I'm going to share some slides. I'm going to take you through some slides. I'm going to play some little clips out of stories that we've shared before, and I've just realised I didn't do that thing that I always forget to do, which is enable the sound, which is useful when you're doing stories. So I'm going to take you through some slides. I'll probably, oh dear, what am I doing? I'll probably be quite quick through the slides and play some clips of stories and talk about impact and outcomes as well. So mention the Heads of Patient Experience Network. We've currently got 900 plus members. The aims of the network are to network, share good practice, develop skills and leadership, influence policy. In July 2020, after the start of the pandemic, we had a kind of influx of people coming to the network wanting to do something that wasn't about surveys and quantitative data. So we started in July 2020 on a storytelling journey. Since then, we've trained 150 people across the network in digital stories. We've also looked at non-verbal storytelling using trauma-informed art, music and drama therapy to explore bereavement. We've done some work around oral history, Schwartz rounds within the network, which is another storytelling methodology that people use. We've used sketch notes and cartoons as well. We've started to embed stories in trusts, but also at the NHS England board meetings, the quality board meeting, each quarter I take a digital story there. We presented at the 10th International Storytelling Conference, which was in Loughborough, which was a bit of a disappointment given that it was international. We're presenting at the 11th, which is in Maryland in the US, but we're doing it virtually because of cost. Not that it's about going to conferences, but it would have been nice. So you may ask, what's a digital story? It's a personal story between 3 and 5 minutes long. The storyteller is the editor. It uses photos or drawings that are from the person telling the story, the filmmaker. It can use video, animation and music. The images or music have to be copyright free. Copy is given to the storyteller. So not only do you kind of have an organisational copy, the person who tells the story gets their own copy with no logos or branding on. 3 levels of consent for a specific purpose, for educational purposes, or you can share it anywhere, including online. We've got 2 ways of doing these digital stories. One that's called the Swansea method. Prue Thimbleby developed this. She's been doing lots of work in Wales. So you record someone telling their story and then edit it back into something that's between 3 and 5 minutes long. Or the California model from the Story Centre, where people think about the story they want to tell, come together in a story circle, tell the story, and then get input from people in that story circle to pin down exactly what that story is. Then they record a script and then they overlay it with photographs and art or video. That one's a little bit more sort of reflective, slightly therapeutic and a bit more creative than perhaps the Swansea model, which is more about improvement. So as well as doing the work across the Heads of Patient Experience Network, we've also been doing some work in the regions. The East of England did some work with allied healthcare professionals. Cancer Alliance's 15 of the 21 have been trained in the methodology. London did some work around end-of-life care. Midlands, health inequalities and the link to research. North Eastern Yorkshire Children and Safeguarding, and Northwest, we did a project in conjunction with John Moores University, the Northwest regional team and Cheshire and Wirral Partnership Trust, which was about mental health and nursing. So just to kind of build capacity in the regions and build information. When we started to do the stories, we wanted to measure impact. So we developed something that was really, really simple. 6 infographics that ask people where they've shared it, which meetings has it gone to, which conferences, which workshops, what was the feedback, what actions have happened as a result of the story. Amplification, we quite like that word because we didn't like the word spread because it felt like butter on toast. So amplification is the number of people who've seen the story in the various different formats, what it's improved and what the impact is. So really, really just top line. I'm going to share a tiny little clip of a story today. This is called Mohammed, A Legacy for Today. It's the story of a gentleman from the South Asian community in the north of England who was diagnosed with COVID February 2021, rushed into hospital, no family with him, no family could visit because of the restrictions. And there was a whole series of microaggressions, errors, assumptions, biases. I'm just going to play a tiny little bit of it so you can get a flavour. And then I'll take you through the impact and outcomes framework for Mohammed's story. It's only about 2 minutes, so we won't take too long.
Dad was acutely aware. He was very aware that as soon as they removed the CPAP, that he would be dying, which I think, you know, adds to the fact that it adds to this unknown suffering of, I guess, what he went through whilst he was in that hospital care. And subsequently, once Dad had passed and we were actually given his belongings, within his belongings, Dad had kind of kept a journal almost of how he was being treated. And there was two kind of key consistent messages that were written within his journal, and kind of his writing deteriorated to the point where it was almost like a child, like maybe a couple of days before, and he wrote the same message that, you know, they weren't coming to give him water and he was being constantly shouted at. And those were the two key messages that we got after he'd passed out from kind of beyond the grave that were left behind from him. And that's when we as a family kind of sat back and thought, you know, we felt such despair that we couldn't do anything to support him in his last 3 weeks, especially the last 2 that he spent in the hospital. But he actually gave us a reflection of what his time was like in the NHS. I can just imagine him coming home and saying, oh, this is what I've experienced, we need to put this right, almost kind of thing. And, you know, that's been the driving force for our family, to get closure, I guess, to know that all the suffering that he followed will actually have a positive impact. It will lead to more awareness within, you know, in the NHS trusts. It will lead to more training. It will lead to more education. It will lead to more accountability so that no one has to, you know, lose a loved one in such a fashion, but actually give staff the right, arming them with the right materials and knowledge that they need to actually prevent this happening from again. You know, that is key, because it's almost coming up to a year, but even now I'll meet people in the community and they'll come and pay their respects for me losing my dad, but they'll always say, but you should never have sent him to hospital. It's almost saying to me that I sent.
So a little clip, and
Dad was acutely,
as you probably can hear from the story, quite an emotional story, an impactful story. It's one of the stories that I took to the NHS England board, and they specifically asked me for a longer story. So the total story of Mohammed's story is about 12 minutes long, which is much longer than it should be. But given that the NHS England Quality Board want a longer story, then I take one. But that's just a little clip around some of the assumptions and some of the things that happened. So in terms of the impact and outcomes framework, that story has been one board meeting, 4 conferences, 4 workshops. We've got over 200 messages of feedback, 16 actions that have taken place so far, 120 views of the video, 920 people have seen it face to face. It's raised and improved the awareness of inclusion issues and ethnicity issues. And the impact is that there are multiple initiatives underway. And then underneath each of those infographics is the detail of where it went. And I won't read through those, but you can see there are 2 different colours there. The dark colour blue is the regional team's work, and the light colour blue is the national team's work. Again, in terms of the feedback, some word clouds from sessions that we've done, also quotes from people. And again, I'll just kind of, but that's the one that always gets me. We failed, we let them down, we must learn. Thank you, Shabir. As others have said, your story is so powerful and will help us make the change needed as part of your dad's legacy. Under actions, again, I won't go through them all, but Shabir, whose voice you heard on the story, has been leading a steering group to decide on the action that the family want to take. It's very much around community work. It's very much around the trust of the South Asian community in NHS services. And it's really interesting that when you take a story to somewhere like the NHS England Quality Board, that what the Quality Board might want to do with the story isn't necessarily what the storyteller wants. And we have to be really mindful of that. Shabia is, if anybody's going to Expo next week, I don't know whether anybody is, but on the 15th of June between 11:30 and 12:30, Shabia, whose voice you heard, is part of a panel sharing the story and talking about the cost of race discriminations and the benefits of tackling it. So if you are there, please pop along on the 15th for the hour, and you may get to meet Shabia. As a result of the story, we were able on the 8th of March to have a community conversation with the South Asian community up in the Leeds area in the North Yorkshire. And we played the story, talked to people about what they wanted. And this is just an infographic around how can we improve experience, how can we involve the community in the conversations, reflections and thoughts. And the little graphic down there at the bottom, which comes up a little bit bigger, I think, here, is the plan for a summer community event around creating some ambassadors and some community champions, having health screening and sign-ups, making it not just a single event, but a series of events, working together with more of the religious groups, really listening. And you can't really see that, but down at the bottom is a little poem that was written about having watched Muhammad's legacy. Amplification, how many people have seen it, what it's improved, microaggressions, the identification of patients when using virtual visiting, care partner advisory board, and ongoing conversations in the local community. Impact, this is just a reflection from the previous National Director for End of Life Care, Wee, who we shared the story with. I thought you'd like to know, and Mohammed's daughters might like to know too. It had a very powerful effect and stimulated lots of discussion, particularly about assumptions and how it affected so much of his experience and that of the family. The conversations that was stimulated by that teaching session are still ongoing, and it's created some soul searching about how policy guidelines and frameworks can be reduced to tasks and what we need to do to push away from that kind of reductionism. We're going to have a follow-up session to discuss, so should we do as a national team to do about this? Once again, thanks for provoking this all for us. So some impactful pauses where they could have just kind of shared the film. They're really thinking about what they're going to do with it. And this is Shabia sharing the film at the event on the 8th of March and her feedback. Thank you to everyone who supported us to share our dad's story. We're so pleased with the way in which we've been able to drive improvements and facilitate understanding for staff in the NHS. So that's an example of the completed framework in terms of all those different areas from Mohammed's story. I'm going to share a clip of another story. Sadly, it's another sad story. It's about Sophie, this lovely young girl who died age 9 of a rare sarcoma. Sophie wrote a bucket list which included riding around in an ice cream van and delivering ice creams to all her friends, having an Australia day, going Prada shopping. She absolutely loved to cook, and she managed to get to cook with Gordon Ramsay. This one may not be so applicable now. I'm almost reluctant to say it, but she wanted to be on This Morning. She managed to get on This Morning with Holly and the previous presenter on there too. But she also wrote on the bucket list that she wanted to improve the quality of food for children in hospital, because she was in 3 different hospitals and she refused to eat because the food was awful and she loved to cook. Her mum wasn't fed in any of the hospitals, so she wanted parents to be fed. And she only got a play specialist 9 to 5, Monday to Friday, and over the weekend when she was having no procedures or treatments, there was no play specialist. So those were the 3 things that Sophie wanted to achieve. And this is just a 1.5 minute clip of Charlotte, Sophie's mum, talking about what Sophie wanted.
She wrote her bucket list, which included some amazing experiences that you would as a 9-year-old. She knew she was dying. We did tell her that. So she knew that writing some of these things on might not achieve in her lifetime that was left, but she wanted to make sure that I achieved them for her. And the 3 were play specialists 7 days a week in all hospitals. She wanted better food for children, and she wanted parents to be fed. And I think to write that on a bucket list, knowing you're dying, I think at any age, just shows how much that meant to her, and how much that actually needs to change. These weren't things that were going to make a difference to her. They wouldn't help her. She obviously didn't, she wasn't going to be in hospital to experience those. But she wrote her bucket.
So again, another tiny clip from a story about Sophie. This one just links the data back. So we'd done the under 16 cancer patient experience survey. We'd had 1,144 survey responses. And for the first time, the NHS England Insight and Involvement team were looking at the qualitative data that came from the survey. So the free text comments, 698 responses. And then by coincidence, the Insight team happened to see Sophie's story because we shared it at a meeting in the nursing directorate. So what that prompted in the person who'd done the qualitative data review was to look at the interrelationship between quant qual and the story from Sophie. So in terms of the cancer under 16 patient experience survey, 88% of parents or carers of 0 to 7-year-olds said the hospital ward offered a play specialist support. So probably doesn't look too bad, probably looks okay. But then looking at the free text comments, we've got the play specialist is friendly but not present, been disappointed by the lack of interaction. And then you kind of overlay that with Sophie's story, powerful, detailed, and speaks loudly on the impact, and links to the other data, and can kind of, the other data together with Sophie's individual story can kind of push back on, well, that's only one story, that's only one experience, that's only one person. So being able to link qual, quant and narrative data in whichever way round it might be has much more power, and that's what we've started to focus on with the providers, doing some work about the links between the 3. And similarly with food, 57%, but you can see that children, Sophie's story tells us that we need to improve food. Focus question, but on its own would be unlikely to lead to wider improvements beyond food choice. And then, some of the qualitative data shows larger national data sets, how widespread the need for improvement is. So just an example of where we've been able to link those stories together. So the impact of Sophie's story is it's been to 6 board meetings, 5 conferences. We've got 180 feedback messages, 12 actions, 700 plus people have seen it face to face, 1,000 people have seen it on the website. And because Sophie's mum had an enormous following on Facebook, 18,000 people have seen it on Facebook. Not entirely sure what that means, but they've been touched by that story in some way. It's improved the awareness of issues for children and parents when they're in hospital. And the really great thing about this story is, I mentioned the Hope Network wanted to influence policy. Well, this story has led to 3 policy pieces of work being undertaken which is to improve the food for children in the hospital, which is happening across the Children's Hospital Alliance 15 sites. We've got a whole review of children's play specialists, and we've got some work going on to pilot how much it would cost to pay for parents and siblings to be fed when children are in hospital. So that feels like a great, big, lovely impact. So those are some of the stories that we've been doing. I'm going to play something really tiny, 2 minutes. This is where we've been breaking out a little bit from digital stories and thinking about how we use more creative means. So the Hope Network, we decided that we would do some exploratory work around poetry, and we engaged a wonderful poet called Beth Calverley, who got some of us together, 8 or 10 of us together in a group. We talked about going beyond the data as the theme for the poems. So we wanted to go beyond the quantitative data. This poem is about voice and connection, and this was created by 10 people in 45 minutes by Beth prompting us to with some questions and us replying with answers, her making notes, and then at the end of it writing this poem. And Ophelia, who's the head of experience of care at Solent, is just going to recite the poem for you.
The Hope Network. We want to be handed our cup of coffee hot and to say thank you to the person handing it. Small kindness, Danusha Lemeris. When I was new in post, I met some people who said, "Are you not part of the Hope Network?" I was. I wouldn't say referred, but I was sent to Hope. I joined just at the beginning of this year, recognising that it's been really hard doing the job through the pandemic, keeping those connections with clinical teams, patients, carers. It's all become digital. In some ways, that's really important, but also it's really hard. I've been embraced, even though I'm not head of. It's that acceptance, that access, knowing you belong, making sure the coffee's hot, saying thank you. I always get here a little bit late, even if I sneak in half an hour before the end. There's always a moment I get. For me, today has been the moment, the fact that this poetry came from Hope. Something in here for everyone, encouraging me to do things that are new, completely different, outside my comfort zone. I feel personally bogged down by the data, ticking a box. We can get so caught up in FFT data, complaints, but you strip it back and it's just somebody who wants somebody to be kind. Let's dig deep. Never forget the people. I've only been to 2 of the meetings, but just to hear that across the country, people are supporting each other, looking at the ways in which voices are heard. It's made me look at what I do. I've started carving out Fridays. I'm calling them Fun Fridays. Every week ends with making a difference. Remember, bravery is the friend of shyness. They work together. At the centre of what's important to people, sipping the multicoloured champagne of pride.
So obviously not a patient experience, but an experience of the people in the Hope Network and what voices and connections mean to them in terms of going beyond the data. Oh, go away, Ophelia, we've heard from you. We shared that at the Heads of Patient Experience conference a few weeks ago, and some other poems. And at the conference, we had half heads of patient experience and half patient leaders. And we got back afterwards this fantastic poem from a lady who was there as a patient leader who'd had a stroke. It was called The Angry Poem because she was very angry at the stroke. And sadly, I haven't got permission to share it, but it's a way of her expressing her experience of that stroke. And then this is just some work we've been doing around using sketch notes and graphics and cartoons and visuals to tell stories. So this is the story of the conference day. So I'm going to be quiet now and stop sharing, and I'm happy to take any questions, and I hope that helped. And thank you for listening.
I mean, thank you for the wonderful stories, and I'll just hand straight over to Gloria, whose hands shot up when you said, do you have any questions?
Thank you, Lesley. That was really powerful and actually not easy to digest, but that's what we need, isn't it? I think we work in an environment where we all try and be very compassionate and take into, make messages sound as easy as possible, but actually that is what we needed to hear, because it really brings it back to why we're doing what we're doing. So my background is I'm a project manager. So I'm thinking already about how I can utilize this type of storytelling. And so usually the way it would go is I'm handed a kind of a project that I need to kind of lead. So if I want to start embedding storytelling into the creation of the project, what does that look like? Because so I come from Sussex, I'm from NHS Sussex. And I can imagine if I decided to go to one of the provider trusts and said, do you have any stories for me so I can really, help to shake up our healthcare system? I probably will be met with a no. There's an IG issue here. So what kind of pathways can we use to embed storytelling into projects? What would that look like? Because I really want to turn this into action now.
Yeah. Well, I can send to this group a list of the trusts that have somebody trained in that storytelling methodology as a start point. I'd probably just have to check GDPR whether I can share emails or whether it's just there is someone in this trust who can do this. I do know there's a lovely lady called Catherine Horner at Sussex and Surrey Trust. I may not have the terminology quite right, but she is a prolific storyteller, and she recently shared a really impactful story about maternity and sadly the death. They're not always all about bad things. It feels like everything I've shown you is about bad things. But she recently shared a really impactful story about the death of a baby 72 hours after birth, where the midwife on the triage line didn't listen, but actually sharing that story has led to some really good improvements. So I can do that for you.
Thank you.
If you want to join the Hope Network,
yeah, I'd love to.
You're happy, you can do. You may find it really tedious. You may find it inspiring. We meet every 2 weeks with no agenda, no minutes. People just come along and share things. We usually have someone who comes and shares something for 10 or 15 minutes, 10 minutes worth of questions and answers. And we also have a storytelling community on the platform. At the moment, I'm not really doing a great deal with it, partly because of the restructure of NHS England and the pressures that brings, but the plan is to move that forward. But I think there's something for people working in your kind of roles, just to kind of find out who your head of patient experience is, either if you've got one at ICB level, some do, some don't, but who is the head of patient experience at your providers. Most providers are doing patient stories in some form, often bringing patients to trust boards, often getting people to write stories and somebody reads it. People are doing it in innovative ways. Some of the work that we've been doing has also been around live performance theatre. We had a storytelling conference in March where we had a lady who had written down her experience over the last 15 years of caring for two young sons who were diagnosed with muscular dystrophy, the 15-year journey of caring for them, negotiating health and social care. She told it through a parallel experience, making it reference to the Three Little Pigs and the Big Bad Wolf. So her and the boys were the Three Little Pigs. Muscular dystrophy was the big bad wolf that blew down the house. So that was fascinating. She was a corporeal mime artist by background, so she had an advantage in terms of performance. But I would say get in touch with your providers. Okay. I'll see what I can share with you. I can definitely share trust names where people have had this training. But there's lots of people out there doing this work.
And actually, on that note, Gloria, I won't say loads, but that's exactly why I started this community, was because, project managers, you often get dealt with sort of, you get given logic, and then you try go persuade someone with facts and figures saying, you know, if you're in NHS England, you normally preface with something, you know, this is now national policy and you need to do it and comply by January. And, you know, as someone in the change space, I've often seen we engage the reluctant minds, but we do nothing to engage the hearts or link hearts and minds together. But I've got to add to Lesley's really helpful list. I've got some other tips and tricks, but I want to hear from, you know, from the room about any questions or observations for Lesley.
Hi guys, can I come in?
Oh, yeah, of course.
Thank you, Bryn. And thank you, Jocelyn, for adding me to the group. Thank you so much. I'm a kind of new member here. And Lesley, brilliant talk. I mean, I work in the National Patient Safety Team, so you can imagine how important patient stories are, you know, when we're talking about big policies. And probably Gloria is aware of a term called PSERF, which is Patient Safety Incident Response Framework. So it's like a massive change in how we're managing incidents nationally. And there's a big team who are doing it on behalf of National NHS England, and I work in NHS England. But on the ground, the trusts and the ICBs are kind of leading the game.
Mm-hmm.
And at the moment, it's basically like different trusts are at different. So there are 7 phases of PSERF. So in short, basically everybody has to reach the 7 by autumn. Now I'm looking to do something that will, you know, the trusts that are not doing so well, or, you know, they're struggling with system pressures. You know, there were staff strikes, there were reconfigurations. There are some genuine system pressures out there. So it's not about a blame game, but it's about encouraging and boosting them to come to that pace where the other trusts are. So I'm looking at something more attractive, because what happens is, you know, we're guilty of preparing documents that are 64 pages long and 68, and I lose people, you know, in all that. And I want to get punchy 2 slides so that I share something with people and they're like, oh, wow, you know, I can do it. You know, encourage them, but also give them the subtle messages that this is the next step. And I did get some tips from yours, you know, those lovely simple post-it thing with something written on it, which actually attracts your attention. And then you go back and start thinking about it. So it's not a question, nobody has to answer this, but I'm going to walk away with some good tips from here. But if there's anything else, feel free to drop me an email. I'm going to put it in my chat. Yeah.
Okay, no worries.
And also, sorry, how do I pronounce your name? Because I'm going to miss. Yeah.
It's Ashutosh, but you can call me Ash. Everybody calls me Ash. So.
Okay, Ashutosh. Sorry, before I sort of mispronounced your name, but you know, I think, you know, if it's something you want to do with this community, well, I'm now volunteering everyone, so please tell me if this is insane. But if you want to feed back and use this community as a sounding board, say, what do you think of the story? What do you think of that? Because I know there's sometimes I get the slight terrors. Sometimes I've like shaped a story, and then I'm like, right, the first time I use this is live with my own team. And it's either going to go really well or or it's not, and I'm going to have to wind it back. So if you want to use this community as a sounding board for your team or anyone else, that I'm getting nods, it would be great to do that. In terms of an added hint, how I've used stories in the context of getting people to continuously improve is I've sometimes done it using a very short patient anecdote. And so I get it in by stealth, so people don't feel lectured to. So I've started meetings, and this was over COVID, where we were improving the online experience for patients through general practice. So, you know, going back a step, we had I had a PDR objective, a performance objective, to over the year increase the uptake of online consultation in GPs from about 40% to more than 40%, or it was 20% actually in my region. And it turned out that all I needed to do to achieve that aim was have a global pandemic, because as soon as that happened, everyone got online consultations. It was done within 3 weeks. But then the problem we had was, you know, because for all the reasons you said, Ash, is GPs were under pressure. As soon as the sort of the government diktat to open, you know, to close your doors went away, people started rebounding, and a lot of patients had actually said, you know what, I really like online. So, and I won't share it now because I feel like I'm hogging the floor, but we had a patient story of their experience of online, or their experience of access. And just by giving that as an anecdote in the beginning of a meeting, it kind of framed the subsequent meeting. Because I remember the first time I said it, a practice manager for a GP said, "Yes, Bryn, that's why we need online." And I was like, excellent. The stories kind of made the point for me without me having to resort to the NHS England, banging of the table and making spreadsheets, So, but anyway, that could be another hint. But we can maybe, if you want, our next session could be unpacking stories for you and using being a sounding board.
Sounds good.
Yeah.
Thank you so much. Thank you.
And I think, Ash, just try and, I feel like I'm leading a rebel movement, but just try and get away from the spreadsheets and the percentages and the documents. And it's, we do need to appreciate, though, that some people love those things and hate stories as well, because there are people who hate stories. Yeah, and in the Hope Network, just completely and utterly dominated by national surveys, percentages of confidence intervals and all that stuff. And every year we churn out these surveys and people never really make any improvements from the survey. But we've got data that goes back 12 years that tell us an incremental 1% improved, and then we slip back 2%. But what did it ever improve? Whereas with some of those stories, we do know that things have changed. Even that conversation about in the South Asian community around Mohammed's story, that that has made a huge difference, and that was really humbling to sit in that room inside that community in a community hall and watch the community watch that story. That was very impactful to me.
No, absolutely, Lesley. Thanks. I know Faith wants to come in, but just a quick thought that came to my mind and it just slipped out. Anyway, if it comes back, I'll come back. Thanks, Lesley. Sorry. Go ahead, Faith. Sorry.
Thank you. I just wanted to go back to Lesley just to say that I think what made the telling of your story so compelling is that you drew that thread from the event, the story, to its impact, and I guess that gets certainly where I work. I'm in projects as well, but I often don't see that thread. So I think it's important that we draw that thread through the stories, and that will increase the impact.
Yeah. And just a little bit of background, just to let people know why I have a passion for stories, particularly. So I've worked in the NHS since 2008. I joined a PCT just as the whole mid-staffs inquiry scandal was beginning to surface. So the focus for me doing that role was around collating people's experience. Did some work around that, worked through the whole mid-staff scandal. Then in 2014, my husband Seth was diagnosed with pancreatic cancer. And for people who may or may not know about pancreatic cancer, it's at the bottom of the survival rates. Survival rates have not changed in 50 years. 1 in 4 people die within a month. 3 in 4 people die within a year. And 45% of people are diagnosed at A&E, and nothing really has changed in 50 years. Sadly, Seth was diagnosed with pancreatic cancer with no signs or symptoms particularly beforehand. He was admitted to A&E for a scan, and the next day was told at 4 o'clock that he'd got late-stage pancreatic cancer and he'd got days, maybe weeks to live. So our world crashed down. We were thrust into a world of palliative and end-of-life care. I was on the periphery of healthcare in terms of working in a PCT. Every day I stood up and asked people to share their experiences with me because we wanted to make improvements. We wanted to hear what people had got to say. As soon as we were in that position, Seth wanted to die at home, but the system sucked him into the hospital to drain fluid from his abdomen. Once he was in there, nobody would listen, nobody responded. I couldn't get him out of there. and sadly he died in a place he didn't want to be. So at that point in time, I was traumatized, I was angry, and I felt like I'd let Seth down. After Seth died, I sat down with his medical records and wrote down what happened on each of the 33 days from his diagnosis to his death. But what I found myself writing was what it felt like to be me, to be Seth, or to be both of us on significant of those days. Tried to share that with the hospital and the CCG, the one who delivered the care and the one who commissioned it. Neither wanted to speak to each other. And 8 months after sharing a set of 17 letters and a journey, nobody came back to me, nothing changed. So in 2016, 2 years after Seth died, I left the NHS because I felt like I couldn't work in it, because I stood up every day and said, tell me about your experience, I want to change things, and nothing changed. So I did some work with the National Council for Palliative Care, which became Hospice UK. We turned Seth's and my experience into a play called Homeward Bound, which took you 2 weeks before Seth's diagnosis through to his death. It was about conversations about compassionate care, about the inadequate care that we got. In 2017, that was turned into a film. And don't feel obliged, but if you do want to look it up, it's on the Hospice UK website, Seth's story. So I spent a couple of years sharing that story with people to create improvement. Couldn't do that anymore because I kind of run out of emotional capacity, came back to the NHS to work in NHS improvement as it was. So that's what drives me, my personal experience of knowing that nobody listened and nobody responded. And it shouldn't take an individual person to turn the key on a change. The system should hear a story, respond to it, and make the changes. So that's why stories are important to me.
No, and that's really powerful, Lesley. Thank you for sharing. Sorry, Ash.
Yeah, no, I was just going to say, Bryn, Lesley, thank you so much for sharing, and our hearts go out to you. Really sorry about your loss. And that's one of the reasons why I am in patient safety. You know, these are the things where patients sometimes end up in the wrong place. You know, cancer is one of the things, but you know, you hear that 9-year-old with sarcoma and things like that, which is also so disturbing. But our hearts go out to you. Thank you so much for sharing that. And you actually reminded me what I was about to say is it's about culture change. So what we're trying in the NHS, well, things take a while to change. You talked about mid-staffs and, you know, Berwick report, Francis inquiries, Ockenden report recently, maternity, and everything tells the same thing over and over again. And then we ask ourselves that why things are not changing. You know, healthcare has been in the thing for what, thousands of years, you know, but why does it take decades for things to change? And what PSERF is trying to do is bring about that culture change, you know, where it's an open culture. It's, as you said, compassionate engagement is part of that, and so many other things as part of that patient safety incident response agenda. And this is again where the stories are going to be very powerful, that if we are walking into a trust which has had issues with culture, they're not going to change overnight. You know, we still see cases coming out, and you probably heard this, that there are 4,000 avoidable deaths every year due to patient safety. And 4,000 deaths, what I do in my presentation is say 4 jumbo jets crashing every year. And would the aviation industry allow that? You know, they would never allow that. Okay, you cannot, it's normally healthcare is compared to the aviation industry, but if we move away from that a little bit, thinking that it's slightly different, you know, there are too many players, there's human factors involved and other things. I think that patients, not just patient stories, but stories are going to be what's important in terms of culture change. You know, people have seen what happens, people have seen incidents. And this is where I think it's not a dilemma, but it's like you're bringing about a radical change in a system. You know, you're bringing radically about compassionate engagement of families and patients involved, but also those clinicians and the staff who work their socks off, you know, and getting away from that blaming game. And, you know, we're moving to restorative just culture in practice. So it's not like a root cause analysis. Not one person is, you don't look for that person or that factor that caused it, but you look at system wide. And this is where the systems engineering and patient safety, so SEEPS is something we're advocating quite a lot. And I go about doing talks and things as well. So we'll really benefit from these kind of conversations, you know, and Breen, I take your offer on that as well, to, you know, use this platform to explore in the future. But Lesley, thank you so much. You know, a lot of food for thought.
No worries, no worries. And I was going to say something profound and it's completely slipped out of my head, so I don't know what it is.
No, it's just like me.
Well, I felt like I was going to say something really important, but it's completely left my head.
But
thank you for that, Ash.
Thank you.
My first thought is that, like, listening to all of those, there's something that's worth calling out, is that the stories about why we do the job help us better sort of connect to our authentic reason and the meaning behind our job, and I'm not going to go into my sort of origin story, but I'll save that for another time. But that is really important in the roles we do in managing change, because we can feel so remote from where things are actually happening. So there's something about reconnecting to the purpose. But actually, maybe I'll say Leslie's profound thing is, I think we are leading a rebel movement, and I think we should add that to our community rules. Because we want to change culture, and I don't think getting a national NHS storytelling framework with certain value points and another spreadsheet is going to be what do it. I think it's going to be passionate individuals who are a little bit impassioned or quite a lot of bit pissed off, just doing this thing. And I think the other two things I'd probably like to add, just reflecting on what everyone's saying, is how we can use this group as a sounding board, and how we can maybe start to use the group to answer Faith's questions that you put in the chat, is like, how do we actually make this change effectively? Because we're all kind of experimenting. I've had the same thing of like telling a story and everyone goes, wow, that's a great story. And then we all look at each other and carry on with the business. And I'm left with this feeling of, oh, okay. So
But interestingly, Bryn, the meeting before that I was on, which was around how people sort of look at experience of care in integrated care systems and some of the issues. One of the questions that was asked of someone who was achieving something was, what was it that drove you as an individual to do that? And what is it about the culture? And is it your drive that shapes the culture? And I think there is something about that, it's not easy to create those stories, but it's relatively easy, and it would be easy to play them at the NHS England Quality Board. But what makes the difference is the people at the Quality Board then want to do something which might not be what the storyteller wants, and that's where you have to be quite strong about, well, actually, what Shabir wanted from Mohammed's story was a conversation with the South Asian community about trust. What NHS England wanted to do was double check the identification procedures for virtual visiting, because Mohammed got mistaken with someone else, and at the point he was about to be sedated, he got connected to the wrong family, which is just unforgivable. But it was an error. Or was it? Or were there underlying biases in the organisation that caused that to happen because Mohammed came from the South Asian community? Would they have mistaken John Smith for John Smith? Don't know. So that's the thing with it. But I think the challenge often is always being authentic to the story, what the storyteller wants. And yes, NHS England can go and do some things out of the back of the story, but that shouldn't compromise what the person wants. And that sometimes is quite difficult to negotiate.
And actually, there's also scope. I think we can use positive stories. Well, I've collected a few positive stories just recently in response to a bit of a challenge, because we were trying to explain, how does this rather vague national digital product make a difference to people, and drawing that out using human examples is meaningful. And I think the thing we're wrestling with is, how do we manage that authentic to real life balance between the fact that sometimes this is a great product, sometimes the service is lousy. So it's getting that balance right. But I'll happily work in the open and show this group anything we're thinking about, and then you can kick the wheels on the idea or tell me it's terrible. But
I've remembered what I was going to say, Bryn.
Yes.
It was about positive stories. So Staff tend to like positive stories, boards tend to like the improvement stories, and staff stories are just an absolute source of insight. And if you can do a story for the same story from a staff and a patient and a carer perspective, or two of those perspectives, that's also really, really impactful. And I'll just pop my email address because I noticed that I had contact details on
And
on the slides.
And Lesley, if this group starts to give you loads of stories and the Hope Network, and of course, some of the stories could be reused by the Hope Network and vice versa. Do we get like badges and stuff?
Yeah, we have I haven't got one on today, Bryn, but we've got, it sounds very grand, a storytelling academy. So what it means is the people who've done the storytelling training, if they do 3 stories and they're able to share them, because obviously there are consent issues, sometimes people don't want the story shared widely. And by the way, Sophie's story that I did share with you is free to share. Mohammed's isn't at the moment, but I can pop the link in the chat for Sophie's story if anybody wants to watch the full thing. We went through the story with Charlotte, but at the end I kept the recording going, and she talked about Sophie as an individual, what Sophie was like. And we also put some video footage of Sophie herself in there. So at the end of the story, we connected the board to Charlotte, whose voice completely changed when she spoke about Sophie as a person. There was this joy in her voice, whereas in the story, it was the pain was in the voice. And then finishing with Sophie made a difference. So if you've got 3 stories you can share, you get a bronze badge. If you do 3 stories in an impact framework, you get a silver badge. We have a gold badge and a platinum badge, but we haven't decided what you have to do to get one of those. But it's something around doing something creative with poetry, live performance, taking it out of the digital arena.
Excellent. So, well, the challenge accepted. We can give you a production line.
Yeah, and I'll send through the link to the storytelling sharing platform. Like I say, at the moment, there isn't a great lot going on there, but there will be at some point in the future when things settle a little.
Wonderful.
Fantastic.
And on that note, I think, Lesley, you've had the last word, which is brilliant. Thank you, everyone, for coming. I'm conscious, we're due to end at 4, and I know people are going to be dropping off to other things. But thanks for coming. Spread the word. Tell your friends. Bring more people. And I'll add some of our reflections from today onto the community. And please just join in there, get your ideas down, and then give your suggestions for the next time we meet, what you would like to pick up as a priority. So thank you, everyone. Oh, before you go, Gloria.
If I just put my email in the chat, please could just drop me a line, Bryn, because it'd be great to see. The conference is quite soon, it's on the 28th of June, but I'm already kind of like trying to weasel my way into, we need patient stories. So it'd be good to just touch base and see how we can make that a reality.
Excellent. Let's weasel. And and actually, and I'll be up at the Confed Expo, Lesley, on the same day, actually testing some of our stories with a wider audience, but nothing as spectacular as Sabir. So hopefully I'll be free and get into that session too.
Yeah, and it'd be really good if you could come and say hello to her and that you've seen the story and the impact. Perhaps I don't know whether you have seen the full story.
Yeah, I think I did. Or I saw.
Yeah, I think we shared it at the storytelling launch thing.
Yeah.
But
no, it's really powerful. So I would like to say in person that it's had an effect, actually.
But thank you for having me.
No, and thank you so much for coming on. I couldn't have thought of a more inspiring sort of start to the community. So we salute you, Lesley. Thanks very much.
Thank
you
very
everyone.
much, Lesley.
Good to meet you
Thank
all.
you, everybody,
Bye.
for attending.
Have a wonderful day.
Thank you,
Bye.
Jocelyn.
Catch you soon.
Bye.
Bye.
Have a great week. Bye bye.